All right, everybody. So we have our presentation from Dr. Colette Olisa on focal atrophy and on structure-focused neurodegeneration convolutional neural network for modeling and classification of Alzheimer's. She was supposed to present yesterday, but she couldn't on the first day, actually. So thank you so much for joining, Dr. Colette. Over to you. You can start your presentation. Thank you.
Thank you very much. Thank you, everyone. As she rightly said, I'm Dr. Colette Olisa, and as a project lead, I'll be presenting this project on behalf of the team members. This project was actually carried out at the University of West of England. I'm currently with Preximed International, which is a company that is focused on building AI solutions for medical diagnosis. So the topic is on focal atrophy, structure-focused neurodegeneration convolutional neural network for modeling and classification of Alzheimer's disease. So I'll begin with the research problem. So it's a medical general knowledge that Alzheimer's disease is a neurological disease that affects cognitive, visual, sensory, and motor functions. And there's been a history of inconsistencies in clinical interpretation of magnetic resonance imaging, amongst other imaging. And these inconsistencies stems from the varying experiences of clinicians, and sometimes they base their interpretations of assumptions, which are usually prone to cognitive bias. Now, there's been a lot of research using machine learning to advance Alzheimer's disease diagnosis. However, the focus has always been on the fine grain, looking at the entire brain region as to whether there is presence of Alzheimer's disease or cognitive impairments, as opposed to localized regions, which is the focal atrophy, where this Alzheimer's disease are more prominent. So therefore, this is the gap that we intend to bridge through this research. And therefore, the aim is to design and develop a deep learning architecture that basically models the structural neurodegeneration of the brain, the cerebral cortex, that's the gray matter of the brain, by discriminating between MCI and ED, and most importantly, identifying those regions of the brain that are mostly prone to neurodegeneration due to MCI or ED, which we classify as, or we term DG markers, that's digital biomarkers, because they were observed from digital informations of the brain as identified by clinicians. So here we have a methodology which comprises of pre-processing steps, as well as the design of a deep learning architecture. So it starts off with some samples of images, well-known images, the ADNI images of Alzheimer's disease brain samples, MRI samples, with samples of MCI and Alzheimer's disease. So the MCI is mild cognitive impairment. So these sets were split into two, the training and the testing. So in the pre-processing for the training set, we focus, so it is a new dimension we kind of looked at, which is looking at every sample, every slice, because each individual slice of a patient, each individual sample of a patient comprises of about 155 slices. So the depth of this of a sample is about 155. And so we looked at it as an independent entry. And the reason being that not all the slices are important. And so we wouldn't want to train the neural network to learn something that is insignificant. And so once those samples were put in as independent samples for each patient, each slices, So we discarded every single slice without the full parts of the brain. And as well, we kind of like put together all the PMCI. So the PMCI is examples of patients who were diagnosed as having mild cognitive impairment, and then over time they progressed to Alzheimer's disease. And then patients who were mild, so the SMCI, the stable MCI, they were diagnosed initially as having mild cognitive impairment patients. And then, but after a period of time, they were still mild cognitive impairment. They didn't progress. So we categorize all those as MCI. And then all the progression from the onset, those that were already diagnosed as ED was defined as being the ED set. Then the processing is the gamma correction, which is a nonlinear transformation function that was able to, we used it to expand the brightness of the samples, and then adopted the minimum maximum normalization to put the samples, the values within the range of 0 and 1. So the same preprocessing was carried out on the testing sets, gamma correction and minimum maximum normalization. And then these sets use the training sets to learn neurodegeneration cues of both MCI and ED using the defined and developed S-Neurode CNN architecture. And then this built or created the S-Neurode model. And for the inferencing, using the testing sets. So the output is to determine or to predict for a given sample of the testing set if a particular patient is MCI or is AD. So we'll delve more into the architecture of the deep learning architecture. So as you can see, this is what it looks like. So we have two convolutional blocks. The first block just have a single convolutional layer and of depth 32. Then the second block have two convolutional layers and of 32 and 64 depths. So each block has a mass pooling layer, and then this fits into the dense layer. Then we actually adopted the dropout layer and then the softmax classifier. So some notable hints of this particular architecture is that for each convolutional layer, it includes the ReLU activation, and then we used the regularized, the L2 norm to regularize learning in order to avoid overfitting. And then, as you can see, there are varying layers of dimensions, and we utilize the dropout layer as already mentioned. This particular architecture maximizes performance compared to other existing and well-known models. So for the evaluation metric, we use accuracy, precision, recall, specificity, and then as well as the F1 score. Then for the data split, as already mentioned, we use the SCORE ADNI patient data sets that is publicly available. But for the sets that were used, we kind of like adopted a publicly existing data set from a previous work that already score-freed, like kind of removed the scores of every patient, only focusing on the gray matter. And then we focused on only the sagittal view. But the evaluation was on different perspectives of this sagittal. So we looked at the mid-sagittal and the parasagittal. And so for the mid-sagittal is just a mid-sections of the sagittal view. And then the parasagittal, so a bit deviation of the mid-sagittal. And the reason for these different views to see the regions of the brain. So you're going to see this subsequent slides, the regions of the brain that are most prominent, since our interest is to be able to like have some digital biomarkers that are cues that clinicians can look at if this is developed into a tool. So the mid-sagittal, a total of 4,228 of which 2,160 belongs to the AD, and then 2,068 belongs to MCI. Then for the parasagittal, a total of 5,520, 2,700 for the AD, 2,820 for MCI. And a split of 18-10-10 ratio was used for the training, validation, and the testing set. So an interesting thing that we observed from our model is you look at the learning curves as well as for the accuracies and the loss curves. There's something you're able to observe that stands out, the S-neural CNN, which we designed and developed. So you can observe that there's a close resemblance between the training loss and the validation loss, and as well as very much minimized within the 0.25 range across board, both for the parasagittal and the mid-sagittal. And the training accuracies, as you can see, the learning curves of, between the training and validation, which shows how well the model fits the given data and is able to learn the independent cues that differentiate between MCI and the AD. So looking at it in detail here on the testing set, so that's on the training and validation. We're looking at it based on its generalizations on scene set. So the accuracies are very, very significant. So you have, so if we focus more on the sensitivity and the specificity, you have 99.0% for the mid-sagittal and 98.5% for parasagittal plane. And why the area under the curve is 98.1, 97.8 respectively for mid-sagittal and parasagittal. So this proves how well the model is able to learn the neurodegeneration cues between that existence in the MCI samples as well as the AD samples. Then using the AUC curve, we're able to confirm the discriminatory capability of the model, despite the imbalance in the data set between the AD and the MCI. Now, more importantly, as I mentioned earlier, being able to identify the regions of the brain. So this was just not on a single sample. So there were several other samples, and how we're able to like derive or come up with this is that we kind of like selected several samples from each patient of the same slice from each patient so that there's no bias. So the same slice from each patient, and then use the gradient and the grad cam, then visualize the heat map analysis of the grad cam using the proposed model. And so we're able to see, as is evident here, so I can highlight this. So you have here the blue region. So the higher so the brighter the yellow, the more significant the region is. As you can see, the blue coded region, which is the frontal lobe. And if you remember, initially I mentioned it affects cognitive. So the frontal lobe is mainly for motor actions and behavior, which is a significant region that is mainly affected by Alzheimer's disease. And likewise, the temporal lobe. So these two are very significant. And as you can see, as observed from the grad cam images, you have both the temporal lobe, the frontal lobe, and the parietal lobe highlighted as being very significant as to differentiating between MCI and AD. So it also gave instances or regions of like the cerebellum, which is motor movements, and then the occipital visual processing. So if you look very deep into the medical literature, you'll be able to observe that these were regions that medical analysis have highlighted as being very prominent or highly affected by mild cognitive impairment and Alzheimer. So the conclusion here is that we've been able to so this CNN, which is a structure-focused neurodegeneration network. So we proposed that and was able to achieve very incredible performance and in identifying regions that are mostly affected by Alzheimer's disease. And we also leveraged the gamma correction technique, and which increased the performance of the model, though it was not obviously presented or highlighted in this conference, because at the time we've not been able to do those analyses. And then we also created, the perspective of evaluation and validation of this model, and the contribution also that differentiates our work from that of existing work is this being able to look at the different dimensions of sagittal views with respect to parasagittal and mid-sagittal, which gave different depths of information or insights into regions where AD and MCI are most prominent. So for the future work, our intention is to minimize the computational cost of the proposed model. And subsequent work will be to combine. So we're going to also use this model and see how it performs with the fine-grained, which is the general view of the brain as opposed to looking at specialized region. So which is what is currently being done. So and then subsequently we'll be able to integrate these two models, and for building a diagnostic tool for AD diagnosis and early diagnosis particularly. Thank you.
Thank you so
Any
much.
question?
Yes, Colette, thank you so much for your presentation.
Yeah.
Now, in terms of questions, one suggestion is to have your other presentation also finished, and then we can combine the questions and ask so that you don't have to, repeat certain things. Is that okay?
Awesome, yeah.
All right, thank you.
All right, thank you.
So our next presentation is also from the same speaker on shadow encoder decoder network for brain tumor segmentation. So I let Colin start.
Okay, thank you. And okay, so the second work was done alongside a neuroradiologist from the University Hospitals Leuven, Limburg, Belgium. And so it's titled Segments, Shallow Encoder Decoder Network for Brain Tumor Semantic Segmentation. Now, the research problem is, so obviously, glioma is one of the most, will I say, devastating, or rather, it leads to death. So there's about 49% of all brain tumors. It constitutes about 49% of all brain tumors. And then 78% of the tumors that are malignant. And the most important thing is that anyone that is being diagnosed with glioma have a survival rate between 12 to 15 months. And so the death rate is really high after diagnosis. And so this necessitates early diagnosis. So if it can be identified early on, then possibly there are some interventions that can be adopted or clinicians can use to be able to mitigate the impact that this tumor will have on the brain. And however, there has been existing work in the field of machine learning that has advanced brain tumor segmentation, so which is the early stage of the analysis. So if they are to do this computationally to reduce the diagnostics time, increase ability to identify this tumor early on, then the chances of addressing this and bringing about some interventions that will alleviate the challenges that patients are being posed with is possible. However, this existing work that we've reviewed as presented in the paper, there's been a lot of computational complexity on existing models. So they've adopted, so the unit of all the models from the early onsets of the brain tumor segmentation showed much more prominence or is better off compared to other models. And so subsequent models have been on an advancement of units. However, they had this complexity problem that are either of higher computational parameters, um, um, and then the performance is not clinically useful because they are still not there. Most of the performances, accuracies have been between the range of 70, 80. So there's this gap existing in terms of like computational efficiency as well as performance needs to be improved. And so this is the focus of this research. And so we've proposed a tumor segmentation framework, which incorporates the proposed novel SEDNet, which is a shallow net lightweight CNN based on encoder-decoder network for semantic segmentation. And we focused on the FLAIR modality on the basis that, so based on the clinical inspiration from the neuroradiologist, that of all the modalities, which is the T2, the FLAIR, the T1, the TIES, as you can see here, that the FLAIR sequences better identifies subtle. So even when this tumor is very subtle and unclear, or with discontinuous boundaries, that they focus more on the FLAIR to be able to categorically identify or predict that there is elements of tumor that is existent in a given slice or sample of a patient's brain. And so for this, we'll focus on the FLAIR modality. So quickly going over the methodology, we have the pre-processing steps, and then for the SEDNet training, the designed novel SEDNet, and as well as some optimization algorithms and the optimization functions and the metrics that was used. So with the contributions of this paper. So for the design model during the inferencing, so giving a particular sample, you should be able to segment the regions of the brain that where the tumor is present. So we look in-depthly into the preprocessor. So the observation that was made through analysis of the existing data sets is that the MRI brain slices, there are corresponding empty masks and as well as non-tumor marks that are present amongst those slices. So just like the Alzheimer's disease, so for the brain tumor data sets, there are about 155 slices as well for each patient. And so the objective is to be able to minimize this signal randomness that might be introduced due to the empty mask, particularly the non-tumor mask. So there are regions where there's a full brain sample, and then the ground truth that was labeled shows some elements of regions of tumor, meanwhile it's not a tumor. And there are several instances of this, which will increase the signal randomness during the training. And we also, intention is to minimize the proportion of noise to signal that has been introduced by this type of non-tumors. So for the segment architecture, just like I already mentioned, the existing unit, which is the foundation model, is of high computational cost. And then the convolutional blocks, sorry, let me hide this. So the convolutional blocks contains expensive skip connections that does not necessarily yield any benefit to the model. So this was the analysis that was made based on utilizing the unit itself. And then it shows that there are many rooms for improvement. And so the objective here with the SEDNet, proposed SEDNet, is to minimize its computational cost. So we kind of like only retained or kind of like looked at convolutional blocks that were very necessary or to the learning of those skills to differentiate between a background from a tumor region, and then to maximize performance as well. So it should be able to like increase performance as well as being able to identify the regions where the tumors are present correctly. Then the objective function during the training. So the main thing that we're looking at particularly is to minimize the loss between the predicted and the actual. And based on our observation, there's a high class imbalance between, because of the regions where there's presence of tumor and the regions where there are no presence of tumor. And then the tumor boundary irregularity is also a significant problem that was identified. And so the optimization problem was addressed by incorporating the binary cross entropy as well as the soft dice laws, which were identified from literature to be able to address these things independently. So the binary cross entropy for class imbalance and the soft dice laws for addressing the tumor boundary irregularity. And so they were combined. So looking at this equation here, the YT is particularly the predicted label, and then the GI J is the ground truth label. So when there's a perfect match, the points will correspond to 1 and 0 otherwise. And the E is the error term. So the proposed objective function is to combine the binary cross entropy laws as well as the soft dice laws. And so we did that through a priority weighted combination whereby more priority was given to the binary cross entropy that addresses class imbalance, and less priority was given to soft dice laws. And this combination improved the performance as opposed to when they were balanced or equally distributed, or when they were the reverse. So for the evaluation metric, so there are two metrics that we used. So we kind of modified the dice score. So unlike the dice score that is currently being used, the modified dice score looks at it differently, inspired by the soft dice laws. And as you can see, we kind of like is a product of this weighted sum, or the product of the summations of the probability, the predicted probability, and in absolute. So it's the absolute summations or between the predicted product of the predicted and the ground truth over the predicted probabilities of the predicted squared, as well as combined with the ground truth squared, adding the error term as well. And so for the Hausdorff score, where we have the equation which maximizes the errors between the predicted and the ground truth labels. Okay, so then for the data splits, the data that was used is the MACI conference brain tumor segmentation challenge data sets. particularly the BRAS 2020. And it contains the 4 tumors, as I already mentioned. We only focused on the flare modality, and they were manually segmented to generate the ground truth labels, which is based on the original data sets. So which were already manually segmented to generate ground truth labels. And so which includes the whole tumor, non-enhancing tumor, peritumoral edema, and the enhancing tumor. But for this particular analysis, we focused on the non-enhancing tumor core, which have not been highlighted in literatures, the peritumoral edema, as well as the enhancing tumor. Then registration, these are the usual pre-processings that were done on the original data sets itself. And this for the splits is also the 80, 10, 10 for training, validation, and the testing sets. Now the learning curves of the model. So if we observe from the learning curves, so this is the DICE coefficient score, the modified DICE coefficient score that we use. And as you can see, both the NCC, the edema and the enhancing tumor, they all performed absolutely well. The model was able to identify those classes of the tumor. So given a particular tumor, what are the different labels or classes that are existent in the whole tumor? And that's what we're able to like separate each of the whole tumor into these independent classes. And as you can see, based on the curves, the given model is a good fit to the data sets. So there was very high performance in terms of like identifying or classifying these tumors and pixel-wise segmentation of the tumors based on their classes. And then the loss that was achieved was as low as 0.05, which was very, very significant. And unlike existing literature where you usually observe the oscillatory oscillations in the learning curves, our particular one is very smooth curve, which signifies how best the model was able to fit to the data and able to learn the cues of each of these classes of the tumor. So looking in depthly into the training, validation, and testing, and most importantly, the training parameters of SEDNET is about 1.3 million compared to UNET, which is about 30 point something million, and other advanced versions of the UNET that were mostly in the range of 5 million and thereabout. And so the SEDNET was just about 1.3 million. So if you look at the performances in terms of, so I'll focus more on the SEDNET-S. So the SEDNET-S is, so after training the model, we created SEDNET-S to be like a pre-trained model, and then use this as well as other pre-trained models to compare how this model performs if it's going to be used as a tool for identifying and classifying tumor regions. So we're going to focus on SEDNET-S. So looking at the training for the NTC, which is the non-tumor cause, so you have about 97%, which is very significant. And this is the DICE coefficient. And then the Hausdorff score is about 0.5. And in comparison to what is achieved in literature, there's been no Hausdorff that has achieved anything that has been below 1 in terms of Hausdorff score. And then the validation is for the NTC is 93%. And then the Hausdorff is about 0.7%. 0.7 is the score. Now, this is in millimeters, actually, yeah. Then how does this perform in, how does our model perform in terms of on scene sets, which is a training set? So 93 point, about 93.36% in terms of DICE score for the NTC, and with a Hausdorff score of 0.6. To see how well the model was able to learn the independent pixel classifications, the pixel classes, the classes of those pixels that are belonging to each of the categories of the tumor. And also signifies that there was no overfitting because of the close resemblance or performance between the training and the validation, and as how well it performed for the training testing set as well, which is shows good generalization. Then so looking at this in-depthly, observing the performance in terms of the different classes of the tumors, the NTC, the edema, the enhancing tumor. So these are the different phases of the preprocessing, though I didn't give all the details of the preprocessing that was done on the data set, but I can explain more here. The phase one, kind of like only the non-empty and non-tumors were removed. So for every single patient, we only removed the what categories of the slides that are empty in relation to the full brain scan, the full brain image, as well as those entries that were non-tumor in terms of the ground truth. So this was only done on the training sets, just to let you know. And then the phase two, so after doing removing the non-empty and the non-tumor slices, kind of like only made sure that every single patient had only 25 samples. And so these are the distributions, which is very significant. So the ranges in terms of the DICE score, they were all mostly in between 0.6, that's 60% to about 100% of accuracies when looking at each of these entries independently. So for the entire 800 samples of from the testing sets, so each of these samples, how do they perform independently in terms of their DICE score? That's what this is revealing, and which is very significant as well. For each of those classes, very high significance of very high accuracies, DICE score was observed. Now, looking at this in terms of visualizing the results on the test sets, so what does the visual tumor segmentation look like? So
Hi,
giving
Colette. Sorry to interrupt. So we are running
yes.
slightly over time. So if you could speed up a bit, that'll be great.
Okay,
Okay.
all right, sure, thank
Thanks.
you. Okay, so as you can observe, so I'm just going to be looking at a single example from this. So given this test image with a ground truth that is already known, how well did the SEDMOT model perform? So this is the SEDNet prediction, which is very, very closely similar to the ground truth label. And of course, if you observe all through, there's a very similar performance across board. And then on the validation set as provided by the MICAI challenge data set for the BRAS 2020, where we do not have examples of the ground truth. And so if you observe very closely, there's a strong similarity between the testing sample and the predicted tumor region. And this can be observed as well across board. Okay, in comparison with existing literature, like I already mentioned, so this particular column is, I'm sorry, I didn't identify this. This particular column is for Hausdorff score. These two columns are Hausdorff score. And why this is for the computational cost. And so these are the different versions of UNET. So UNET that was enhanced by attention mechanisms. The dice score is 85, Hausdorff is 6 on the same data sets. Then with the transformer UNET model, 83, and there was no Hausdorff score. ResNet UNET model about 80, no Hausdorff. And then for the SEDNet, we are focused mostly on the edema. So we achieved a dice score of 90.61 and a Hausdorff of 0.77. Then the computational analysis using MAC and flops. So the MAX is the number of multiplications that were accrued by the model in its performance and its computation, and the flops, the floating point operations. So for ours, the MAC in terms of in gigabyte per second is just 0.00138 multiplications, and the flops about 0.00277. That's in gigabyte per second. And the entire parameter is just about 1.3 million thereabouts. So in conclusion, we've been able to show that despite the lightweight of the model based on its number of parameters and small MAC and flops, which shows that is speedy enough to be used in clinical practice for identifying tumor regions, segmenting them. It also achieved very high performance compared to existing models, and then is a 95.67 performance computational cost reduction compared to UNET, and achieve state-of-the-art performance in terms of dice score and Hausdorff, and which makes this model useful for clinical use. And so for future work, we'll be looking at a couple of things, incorporating creating a tumor size estimation using the existing model, and looking at other modalities which give different information to neurologists. The T2 estimating cellularity, and the T1 predicting blood-brain barriers, how it affects. So in terms of looking at the risk analysis of a particular tumor. And then we could explore the attention mechanism and to see if it's, or the transformer, if it improves the SEDNet itself, as the SEDNet shows better performance compared, non-performance, better computational costs compared to UNET, which are the basis of other attention mechanisms, improvements or enhancements. Thank you very much.